Yeah. Good evening to everyone. You're welcome to another session of the educational activities of young African neurosurgeons. Today we're going to be talking about the tuberculosis of the central nervous system. You know, this month we celebrated the World Tuberculosis Day. So this is a very important subject, especially in Africa, as we know there's a very close relationship between tuberculosis and HIV. The president of the Continental Association of African Neurosurgical Society is on his way. He'll be here soon. So we'll move on with the program. Once he comes in, then he's going to maybe to say a word to the panelists. You're all welcome to this webinar. Kabile can give them a rundown of the program so we can start.
Oh, definitely. Welcome, everyone. You can just give me a few seconds.
Can you share the, yeah, okay.
Sure. So welcome, everyone. It's a pleasure to have everybody join us today. We've got a very busy program. So particularly, the first thing I want to do is I think Ignatius will be taking us through the acknowledgements.
Yeah. So as I said before, while waiting for the council president, I think we'll go on. But before that, I just like to thank everyone that participated in the preparation of this meeting, the education team, and then with our graphic designer, Chidi, who has been putting so much effort in the background to make things work. And with that much ado, I think we have to move forward to give a rundown of the program.
Okay. So today we've got a very interesting program, and we just would like to take a chance to welcome everybody. First and foremost is it's World TB Day. So as we know, on the 24th of March, it was quite an important event. And it's a disease that impacts millions of people within our continent. And one of the quests of World TB Day, which was on the 24th March, is public education. But beyond that is also as a medical community to combine and just see how far we've come with treating the disease. We still have quite a long way to go because TB still accounts for 25% of deaths in our continent. When we're looking at global deaths. So the next thing I will do is that on screen you can see our program, and I'm going to move on to my next slide and introduce our moderator. So this evening I'd like to welcome Dr. Luxwell Jokonya. Dr. Luxwell is a neurosurgeon based in Zimbabwe. He is also program director of neurosurgery at the University of Zimbabwe. He also did his training as a fellow in pediatric neurosurgery, and he will be running the program for us today. So Dr. Luxwell, I'll be handing over to you.
Right, thank you very much, Ngobele. It is indeed my honor to be able to moderate this very important update on tuberculosis. And as has been said, that this is certainly Tuberculosis Month, and tuberculosis is quite important in the neurosurgical domain, again, particularly in that it affects the brain as well as the spine. So we're going to kick off the program starting off on a topic on the medical management of hydrocephalus in TB meningitis. And to take us through that is Professor Solomon. So Professor Solomon is a pediatric neurologist at Tygerberg Hospital, as well as the Department of Pediatrics and Child Health at Stellenbosch University. He did his MD-CHB and MMed, as well as he did a PhD in the early diagnosis of TB meningitis. So he's done quite a lot of work in the management of TB. And has written a number of peer-reviewed papers, and is also a member of the Tuberculosis Meningitis International Research Consortium. So I welcome you, Professor Solomons. You may go ahead and your presentation.
Thank you for the welcome. I'll switch off my camera and start sharing my screen. Okay. So just to make sure you can all see my screen.
Yes, we can, Prof.
Yes. So Thank you very much, Luxwell, for the introduction and the welcome. It's my privilege to be speaking on TB meningitis. Just a bit of background. So I'm a pediatric neurologist at Tygerberg Hospital, and we see, unfortunately, lots of children with TB meningitis. We average 50 admissions a year, and with a BCG shortage in our country of a few years ago, we hit 100 admissions a year, mostly stage 2 and 3 TBMs. So we see, unfortunately, huge numbers, and you try to make things better. We do look after, especially the children under pediatric neurology, but working very closely with our neurosurgery colleagues. So as you can see, my topic is the medical management of hydrocephalus in TBM. But I first have to start with just a bit of background on TB and TBM, just as an introduction to the subject. So just a bit of epidemiology. If you read the WHO Global TB Report of 2020, about a quarter of the world population is infected with Mycobacterium tuberculosis. That's huge numbers. And in 2019, there were 10 million new cases of TB worldwide, and a quarter of that was in Africa. So, I mean, definitely a huge problem for our continent. About 1.2 million deaths in 2019 in HIV negative patients, and about 208,000 deaths in persons with TBM and or CNS TB and HIV co-infection. And according to the NTB strategy, the decline in the TB disease burden was too slow to reach the first 2020 milestone, that is a falling TB incidence of 20% between 2015 and 2020. But Africa did well. We basically dropped by 19%. So we are doing something right, which I think has got a lot to do with sort of the groundwork, the primary healthcare work. So just to speak a little bit, one slide on the Sustainable Developmental Goals and those 2020 sort of milestones that were supposed to be reached. I spoke about the first one, 20% reduction in TB incidence. So there was a 9% reduction worldwide. As I said, Africa was 19%. The aim was to reduce TB deaths by 35% between 2015 and 2020, and there was only a 14% reduction. And then they also looked at percentage of people with TB facing catastrophic costs, and the target was no persons facing catastrophic costs of TB by 2020, but unfortunately 49% of people with TB face catastrophic costs that basically decimate the household sort of income and funds, and people have to make loans. So, I mean, huge problems across all spheres. And just some more TB slides. I mean, you can look at the TB incidence rates. I mean, TB in Africa is very predominant, especially sub-Saharan Africa. I mean, you're looking at incidence rates of above 200 per 100,000. So definitely a problem for people to focus on. So what do we know about the incidence of TB meningitis? Well, there's some epidemiological studies that show a good correlations between incidence of TBM in children under the age of 4 and the annual risk of TB infection times 5. So that's a way of working it out. So using that in Southern African townships, there's an annual risk of TB infection of 4% per annum. So you can kind of work out that the annual TBM incidence in these townships are about 20 to 100,000 children. And using hospital-based surveillance strategies, and there's lots of research coming out on this, in children at least, we're looking at 15.7% of all children admitted with TB having CNS tuberculosis. And in the Western Cape, TBM is the most common type of bacterial meningitis that we see in sort of the Cape Town setting, much more so than your traditional pneumococcal, Haemophilus, and other common forms of bacterial meningitis. So I don't have to tell neurosurgeons about the macropathology of TBM. You know this much better than I do. But basically, dense infectious exudate forming at the base of the brain, and this causes CSF obstruction, and this leads into today's topic of hydrocephalus. The dense infectious exudate, if it's sits around the arteries, causes periarteritis, can cause stroke. If it surrounds your cranial nerves, it can cause cranial nerve dysfunction and sometimes can directly affect brain tissue, especially the brainstem. And these persons usually present in stage 3 TB meningitis. So just about the staging, I'm sure you all use the staging basically internationally. The consensus is that we use the MRC criteria. Basically stage 1 TBM presenting with very non-specific signs, coughing daily for more than 2 weeks, vomiting, poor weight gain, and there's absolutely no way to tell that there's neurological involvement. And the difference between this and something like influenza is that the symptoms are quite persistent. So if you have very non-specific symptoms lasting for longer than 2 weeks, you have to think about TB at least, and TB meningitis in a TB endemic setting. And then in stage 2, we see neurological signs. Your meningism, raised intracranial pressure from hydrocephalus, mostly weakness, and then with or without a depressed level of consciousness. And then stage 3, and unfortunately many of the patients that we see present in stage 3, and these patients present in coma with possible brainstem dysfunction and quite severe focal deficit. And if you look at studies, about 15% of your patients are going to present in stage 1, 50% in stage 2, and 35% in stage 3. So the bulk of the TBMs are stage 2s and 3s, and these patients have neurological signs mostly because of hydrocephalus. Clinical presentation. Most of the patients have long symptom duration, more than 5 days. They present with altered level of consciousness, and then fever, vomiting, seizures, weight loss, cough, and headache less common. And on examination, 3/4 of the patients are going to present with a glaucoma scale of less than 15, 17% with raised intracranial pressure, and sort of usually due to critically raised or critical hydrocephalus, about 1/3 with meningeal irritation, about 1/3 presents at admission with hemiplegia, and about 1/3 with cranial nerve palsies. And on neuroimaging, what do you see? I mean, there's lots of studies, and the average number is about 8 out of every 10 patients are going to present with hydrocephalus. Those are huge numbers. About 1/3 with infarction, 3/4 with basal enhancement, and about 20% with tuberculosis. And if you look at the spectrum of TB meningitis in a whole, basically you can divide it into 3 categories. You're going to see the end result of raised intracranial pressure, which is usually due to hydrocephalus. You're going to see end result of vasculitis, which is your strokes, and in especially your HIV and TBM co-infection patients, you're going to see the end results of immune reconstitution. And just the last few slides before I hit hydrocephalus, just about sort of the anti-TB therapy. Lots of people use different medications in different places. And I mean, they looked at, evidence behind WHO guidelines for children, especially. I mean, what is the most appropriate antimicrobial treatment and what is the most appropriate duration? And basically there is poor results. So all trials had limited power, poor methodology, and there's varying treatment regimens with conflicting results. So at the moment, it's impossible to assess what the most appropriate antimicrobial regimen is from the available literature, but there is definitely ongoing studies looking at treatment and treatment duration. And if you look at the first line anti-TBs, most commonly We use isoniazid, which has good CSF pre-penetration, rifampicin, moderate to poor CSF penetration. They're even going up to 60 milligrams per kilo now of rifampicin and higher, and there's better CSF penetration the higher you go. Pyrazinamide has good CSF penetration. Ethambutol is horrible. There is very poor CSF penetration. It's excellent for bone penetration, but not good for CNS TB. And then I think some places still use streptomycin. It's a poor drug to use for CNS TB. It doesn't cross the blood-brain barrier at all. And then some of the newer second-line anti-TB agents. In South Africa, we use lots of ethionamide. It has very good CNS penetration. There is some side effects of nausea. And then the newer drugs, your fluoroquinolones, have moderate to good CSF penetration. And these are ethionamide and the fluoroquinolones are most people's choice for the fourth drug to add in your multi-drug resistant TBMs. Tirizidone has good CNS penetration, and the rest have pretty poor penetration besides for linezolid, which they do use in MDR TBM. And this is just a summary slide on the treatment recommendations. WHO and UK recommendations are basically 12 months treatment for TBM, isoniazid, rifampicin for 12 months, and then pyrazinamide and ethambutol for 2 months. Ethionamide is not recommended. In Tygerberg, in my hospital, we use a 6-month regimen, high dose, isoniazid, rifampicin, pyrazinamide, and ethionamide. And basically, there's a trial going on testing our regimen in sort of multi sites, because there's quite good morbidity and mortality outcomes. It's a combination of shortened therapy, less side effects, but also sort of quite high doses. And then also people use high dose steroids, corticosteroids, for 4 months and taper over 2 weeks. So I have to tell you about all of that before you get to hydrocephalus, because that kind of leads into the problems that one faces. So, as I mentioned, the most common cause of raised intracranial pressure in TBM is going to be hydrocephalus. And in the majority of TBM patients, communicating hydrocephalus is observed, and this is caused by exudates in the basal cisterns, and this results in disruption of CSF flow. There is reasonable evidence and sort of lots of papers that have come out that suggest that hydrocephalus in TB meningitis can be treated medically with diuretics. Some centers even use repeated lumbar punctures. For me personally, as a pediatrician, I would opt for the naturally for the medical treatment, because it's quite invasive to do daily lumbar punctures, but both have been shown to actually reduce the hydrocephalus, especially in children. Your non-communicating hydrocephalus, your problem here is obstruction at the level of the cerebral aqueduct or the outlet foramina of the fourth ventricle. This is much less common, about 20% of your hydrocephalus seen in TB meningitis, and this is treated with a VP shunt or endoscopic third ventriculostomy. So conventional CT imaging cannot reliably determine the physical position of the CSF block, and there have been studies looking at this, because people propose looking at your Sylvian fissure widening and looking at the cisterns, but there is no significant difference between non-communicating and communicating hydrocephalus based on CT. So air encephalography is considered as the gold standard to distinguish between the two types of hydrocephalus. As air encephalography involves a lumbar puncture, there is a technical risk of cerebral herniation, and this puts lots of people off. In more than 1,000 TBM children at Tygerberg Hospital in Cape Town, we've had no adverse effects performing air encephalography. And people always ask you, encephalography, is sort of quite archaic, and can't we use newer techniques? And people have mentioned in papers things like thin slice CT of the posterior fossa or MRI CSF flow studies. While thin slice CT hasn't been shown to be effective to distinguish, I think there is merit in MRI CSF flow studies. But I mean, I don't know how many centers in Africa has access to such imaging. It is usually a 3 or sort of a higher Tesla MRI, and we definitely don't have one at our center. So if you're in a resource constraint setting, encephalography in the right sort of definitely has a place to distinguish between the two. And I mean, why do you do it? Well, if you can prove communicating hydrocephalus, this patient can go into medical treatment, and you avoid all sort of your complications and adverse effects of sort of placement of a ventricular peritoneal shunt, especially infection. I mean, this obviously, I think you would all recognize this. Typical CT axial images of TB meningitis. On the image on the left, sort of blown lateral third and fourth ventricles. There's florid basal enhancement and basically a left-sided infarction. And the image on the right is a different patient, also sort of large lateral ventricles, large fourth ventricle, florid basal enhancement, and a massive infarct in sort of your right-sided MCA territory. And MRI is always better than CT scan, but not for hydrocephalus. So there have been studies looking at the different modalities where they perform both in the same patient. MRI shows better basal enhancement. It shows more infarcts, especially in the brainstem. It shows more of the small granulomas, but both modalities detected hydrocephalus equally. This is the algorithm that we use in our setting. It is for children. But I mean, keeping in mind that sort of your most common age of TB meningitis is between the ages of 2 and 4. So if you have a child that you suspect with TB meningitis, or even an adult, you do a CT brain, and this is going to show, more often than not, it's going to show tuberculous hydrocephalus. We look at the clinical condition of the patient. If the patient is clinically compromised and there's signs of impending herniation, you immediately refer to neurosurgery for CSF diversion. If the child or adult is not clinically compromised, we go ahead to perform an encephalography, and I'll show you a slide in a bit. About 80% of more than 1,000 children have had communicating hydrocephalus, and 20% is non-communicating. So the non-communicating immediately gets referred back to the neurosurgeons for urgent neurosurgery, and the communicating hydrocephalus patients get treated with acetazolamide, and the dosing range is about 50 to 100 milligrams per kilo per day in 3 divided doses, and furosemide, a milligram per kilo per day in 3 divided doses. And this normalizes intracranial pressure within a week of therapy. And then further studies to this 2014 study by Ronald van Toren has shown that it takes 72 hours for the acetazolamide and furosemide combination to decrease the intracranial pressure to normal levels. And in our setting, we have clinical improvement in more than 90% of cases, and we do follow up regularly until treatment completion. And in less than 10% where there is clinical deterioration, this is usually within sort of your hospital admission period, we repeat the CT scan, and either this shows brainstem infarction, new infarction, And if it does show worsening hydrocephalus, and these are minimal patients, these then get referred back to the neurosurgeon for urgent sort of CSF diversion. So this algorithm can only work, the medical treatment can only work if you have a good relationship with the neurosurgeons, or the neurosurgeons are looking after the patients. So what does the encephalogram procedure entail? So same procedure as a lumbar puncture, sterile procedure. You tap 5 to 10 mils of CSF and inject 5 to 10 mils of air. And you follow this with a lateral skull X-ray within 2 hours, and the patient is upright. The needle and the syringe is removed at the same time, otherwise there's going to be leakage of air. And the presence of air in the lateral ventricle confirms communicating hydrocephalus. Air at the base of the brain in the prepontine cistern without any air visible in the lateral ventricle indicates non-communicating hydrocephalus. So these are just 2 examples of communicating hydrocephalus. You can see air in both of the lateral ventricles. In communicating hydrocephalus, if you take an opening pressure with lumbar puncture, your lumbar CSF pressure is equal to the interventricular CSF pressure. As I said, the medical treatment normalizes the intracranial pressure in more than 90% of cases. And furosemide is obviously a loop diuretic, and the acetazolamide is a carbonic anhydrase inhibitor. This decreases CSF production by the choroid plexus and has the added advantage of increased cerebral blood flow and decreased oxygen consumption of the brain. It drops the metabolism. So I think the latter 2 also plays a role in your critical TBM patients. This is a study by Ronald van Toren that basically shows in 16 patients a drop of intracranial pressure by day 7 to within normal limits. And the acetazolamide does have a rapid onset of action, and there's inhibition of CSF flow once 99.5% of the choroid plexus carbonic anhydrase is inhibited. So you need at least 50 milligrams per kilo. And usually by day 3, there's a significant drop, and with improvement in the child's clinical condition. So in non-communicating hydrocephalus, as I said, there's obstruction of the 4th ventricle foramina. Often these patients present suddenly, and there's progression to coma and brainstem signs. And the treatment here is urgent VB shunt or 3rd ventriculostomy. And you can see the air in 2 separate patients being stuck in the basal cisterns and nothing in the lateral ventricles. So in an unpublished or to be published study, one of my MMeds looked at 443 children with tuberculous hydrocephalus. 28% had non-communicating hydrocephalus and 318 communicating. And besides for prolonged duration, more than 5 days in the non-communicating hydrocephalus and more strokes in the non-communicating hydrocephalus, there was no other clinical, CSF, or radiological association that was identified or differences between the 2. So in conclusion, non-communicating hydrocephalus is virtually indistinguishable at presentation from communicating hydrocephalus. Encephalography remains essential. There's a good safety profile in our center in more than 1,000 children. And the touted alternatives such as thin slice CT and MRI flow studies are not easily available in resource-constrained settings. Neurosurgery is essential in non-communicating hydrocephalus and for vigilance in worsening communicating hydrocephalus on treatment. And basically, if you go the encephalography route, your neurosurgeon must be at sort of close hand and sort of also sort of work hand in hand with a treatment protocol and algorithm. And I think I am done. Thank you very much.
Okay, thank you very much, Prof. Solomon, for a very, very interesting talk. I think it's actually very, very relevant, particularly in Africa, where sometimes you have problems with access to surgical management of the hydrocephalus in tuberculous meningitis. But if I may ask a question,
Yeah, sure.
if you, so to compare the outcome with regards to those patients that are managed with shunts versus medical management might be a bit difficult because obviously there are different sort of clinical staging or grading. But if we were to look at those perhaps that are amenable to medical treatment, and then would you know of any maybe trials that have been done, or from your experience in terms of trying to see those that are medically managed versus those that are managed surgically, whether there's any difference with regards to the outcome? Since we know, of course, that the medical management will take about a week before your ICD starts normalizing. Does that have an impact in the?
No, that's a good question. It's going to be the only way to do a randomized control trial with the two events, but the people are quite sort of passionate with their treatment choice.
Okay.
You get your advocates of early CSF diversion. You have the advocates of repeated lumbar punctures, and the advocates for medical management. And I promise you, in the international community, there's no accepting of both thoughts. So basically, you need a center, where you can randomize patients to either CSF diversion or medical management. But there is no studies with a head-on-head comparison. Obviously, an RCT will sort it out once and for all. So I have strong feelings on medical treatment. I think it has its place in selected patients, but unfortunately, there's definitely no studies to compare.
All right, thank you very much. Definitely, I agree. So I did witness firsthand in terms of the outcomes with medical treatment when I was doing my fellowship in Cape Town. So it's actually quite interesting, and I think it's a very good protocol to take up. Okay, so moving on. So for the panelists, if you've got any questions, please feel free to post the questions on the question and answer, and then we'll get back and answer those questions. So right now I'm going to hand over to Beverly to introduce the next clinical presentation.
Thank you very much, Luxwell. It's with great pleasure that I introduce Dr. Justin Onen. He is one of 10 neurosurgeons in Uganda, which has a population of 44.27 million. He trained at Musara University of Science and Technology before proceeding to the WFNS Training Center of Mohammed V University at Rabat in Morocco. He returned home in Uganda and did a fellowship in pediatric neurosurgery at the Cure Hospital Uganda in Mbale, which is world renowned for its work around hydrocephalus. He has since moved on to work at the International Hospital in Kampala, and it's with great pleasure that I welcome him to the webinar.
Okay, you may go ahead and share your screen. Is he able to share your screen?
In the meantime, maybe Dr. Jokonya, we can move on to the clinical case. Oh, there, he's back with us. Thank you so much. He's back on. Dr. Onen, we ready for you to share your screen?
Dr. Onen, the stage is all yours. Thank you.
Sorry, are you talking to me?
Yes, please.
Go ahead and share your screen.
Sorry, I've gone off. I've just come back on.
All right, sure. Please go ahead and share your screen with the clinical presentation.
Just a minute, please. Just a minute. I'm having a bit of technical problems.
Not a problem at all, Dr. Nen. We'll give you time to just sort out that question, that problem. Maybe Dr. Jokonya, you can have another question for our speaker, and Dr. Onen. Oh, perfect, excellent, thank you.
So, what was the question about? Sorry, I'd gone off.
No problem. You can go ahead and start your presentation.
From beginning?
Yes, please.
Yes, please.
Yes, so I'm majorly going to talk about my small surgical experience with cerebral tuberculosis, more especially in line with the hydrocephalus. So we have already, we celebrated the World Tuberculosis Day during the week. So central nervous system tuberculosis caused by the Mycobacterium tuberculosis is highly devastating. So that's what we should all know as a take-home message. And it accounts for about 1% of all cases of tuberculosis and 5 to 10% of the extra pulmonary cases. So you can see it's quite a big percentage. It carries a high rate of morbidity and mortality, and it mainly afflicts children and patients with living with HIV/AIDS. You can already see the new cases in 2017, there are about 9.27 million cases and about 13.7 total cases reported at that time. So there are some risk factors that I've highlighted, and this includes HIV infection, which is the biggest risk factor in our communities. The overcrowding also contributes, and overcrowding in abnormal communities, such as in prisons, concentrated camps, and refugee camps. And of course, undernutrition and appearance of drug-resistant strains and ineffective tuberculosis control programs. There's also increased immigration from countries where tuberculosis is prevalent to developed world. We've classified into the CNS tuberculosis into intracranial and then the spinal. And the bigger majority is constituted by meningitis, a very small percentage of encephalopathy, and a equally small percentage of tuberculous vasculopathy, tuberculomas, and the abscesses, which are tuberculous in nature. Then there's also the spinal component, which is constituted by Pott's spine and Pott's disease, non-osseous spine tuberculosis, spinal meningitis, tuberculous arachnoiditis, and then the syrinx formation, which can be seen in some instances. Professor Solomon has already spoken about the staging, which has mainly 3 stages. And you can see stage 2 has a Glasgow coma. Those ones may have a Glasgow coma scale that is a little bit depressed, between 14 and 11, or 15 with focal deficits. And 3 is, of course, less than 10 in the Glasgow coma score. So the pathogenesis of CNS tuberculosis, you find that the hematogenous spread mainly from the lungs constitutes the bigger part of spread, with visible focus in almost 30% of the cases in the lungs. So it develops in 2 stages. Infrequently, the infection enters the CNS through tuberculous otitis or calvareal osteitis. That one is a very rare occurrence. And initially, there's what we call a Rich's foci, which forms and then later expands. It might stay quiescent for many years. And you may find it in the meninges, the subpial area, the subependymal area of the brain, and the spinal cord. Just as I said, it might stay dormant for many years, but later, rupture or growth of one or more of these lesions may lead to various forms of tuberculosis. And of course, immunological mechanisms are thought to play a role in this. So the type and extent of lesions that result from the discharge of tuberculous lesions will lead through the CSF will depend upon the number and virulence of the bacilli and, of course, the immunity of the host. Those ones play a big role, sorry. And immunological parameters show that children who develop tuberculous meningitis, had lower numbers of CD4 lymphocytes. So a lower number of CD4 lymphocytes might count for those who get extrapulmonary spread of the TB. And that's why in HIV/AIDS patients, you also get those who develop CNS tuberculosis. Pathogenesis continuity. It has been generally accepted that with a sizable inoculation, in the absence of an adequate cell-mediated immunity, the patients might develop tuberculous foci in the cerebral tissue, and may develop into tuberculoma or tuberculous brain abscesses. Of course, clinical features have already been spoken about. This could be long-lasting before development of these other CNS symptoms. And of course, these are constituted by the non-specific symptoms, including malaise, fatigue, anorexia, fever, and headaches. And then prodromal symptoms in infants are a little bit different from those in adults. And you may find irritability, drowsiness, poor feeding, and abdominal pain. And these are some of the things that do not point towards tuberculosis. And we can easily miss the diagnosis because we end up looking for other diseases. And then eventually these patients worsen, and of course the headaches get worse, they're stiff, and then the necks become stiff. Meningismus, bulging fontanelles in children, nausea, vomiting, altered sensorium, or reduced level of consciousness. And then there's a prior history of tuberculosis in almost 50% of children and 10% of adults. Cranial nerve palsies might occur, and then visual loss, which can be due to optochiasmatic arachnoiditis or direct compression from hydrocephalus in the third ventricle. Optic nerve granulomas can also contribute to blindness, and of course, we should not forget ethambutol toxicity when treatment has already been started. Focal neurological signs such as hemiplegia or paraplegia or quadriplegia might also develop, but the most common is the hemiplegia or hemiparesis. And of course, some patients might develop movement disorders in the form of choreiform, hemiballistic movements, athetosis, generalized tremors, myoclonic jerks, and ataxia. And of course, some of them go ahead to develop seizures, which can be partial or generalized. And in the disease progression, more cerebral dysfunction occurs, leading to apathy, irritability, eventually lethargy, then stupor and coma. Terminal illness translates to deep coma, decerebrate, or decorticate rigidity and spasm. And of course, diagnosis is divided into three, mainly clinical, laboratory, and imaging. And of course, clinical diagnosis constitutes almost 50 to 70% of your diagnosis, followed by a laboratory, mainly utilizing CSF, and then imaging, which is mainly CT scan and MRI. Cerebrospinal fluid. Cerebrospinal fluid is the predominant, in cerebrospinal fluid, the predominant cells might be the lymphocytes, which might constitute 60%, and of which you find 60 to 400 white cells per milliliter. And of course, there's raised protein. And in the early stages, there may be a predominance of the polymorphonuclear cells, which gradually changes to the lymphocytic cellular line. And there's a gradual decrease of sugar, glucose in the blood and in the CSF. And in this case, definitive diagnosis is finding the tubercle bacilli in the CSF by either a smear examination or a bacterial culture. And the highest detection rate is in the ventricular fluid, not the spinal fluid. Bacteriological conformation is still dismal, and of course 10%, even with all this smear and culture, still 10%. So there's heavy reliance on the clinical diagnosis, which constitutes 25 to 70%. And of course, culture takes several weeks, and if it's not put on the rightful culture medium, there might be no growth. And a liquid culture medium is preferred to a solid one. And of course, to increase on the diagnostic yield, Other diagnostic mechanisms have been employed, such as the ELISA, the latex particle agglutination test, and of course the PCR, which is deemed the best test for this. Going to imaging, we have CT scan and MRI scans, and these are some of the things you'll see on those scans, like meningeal thickening, especially in the basilar regions, including the Sivian fissures. I think you've heard of the spider leg kind of appearance. And of course, there's hydrocephalus, and then infarcts, which can be seen in about 20 to 38% in the thalamic, basal ganglia, and internal capsule areas. Tuberculomas can be seen about 10% in culture-positive patients, and multiple in those who have a miliary picture. Low or high density on CT scan, that's how they appear, with ring enhancement after giving contrast. MRI will also depend on whether caseating or not, with a difference in the center. Tuberculous abscess, which can be found in 4 to 7% of these cases. It's a granulomatous liquid, it looks granulomatous with a liquid component in the center, which is hypodense. And of course, tuberculous abscess is much larger than tuberculomas. And of course, it has always marked surrounding edema. And in centers which have sophistication, angiogram can also be employed to demonstrate uniform narrowing or irregular beaded appearance of the lumen of these vessels, more especially in the circle of Willis, or total occlusion. And these vascular changes are due to either vasculitis or compression by basilar exudates. Going to the port spine and ports paraplegia. In this case, some surgeons claim that conventional X-rays can adequately demonstrate the destruction of the bones, adjacent vertebrae. However, CT scan and MRI scans may give more detail. And of course, there's a non-osseous spinal tuberculosis, in which you can find extradural tuberculomas, arachnoid lesions with dural involvement, or you get subdural lesions, which are either extramedullary or intramedullary. And in this case, the MRI is the investigation of choice. Spinal tuberculous meningitis, in this case, MRI shows CSF flocculation and obliteration of the spinal arachnoid space with loss of outline of the spinal cord. And of course, you find matting of nerve roots in the lumbar region. This might be associated with the syrinx. Of course, treatment, there's medical treatment where the anti-tuberculous regimen, like Professor has already spoken about, there's no clearly acceptable regimen, but generally isoniazid, rifampicin, pyrazinamide are used in combination, and rarely in our setting, ethambutol or streptomycin is added if the response is not satisfactory in the initial few weeks. And then initial and continuation therapy combined is either between 6 and 12 months. And of course, for atypical mycobacteria, more especially HIV patients, 4 regimens are utilized, which might include azithromycin and clarithromycin, or with ethambutol or clofazimine. And of course, the role of corticosteroids in tuberculous meningitis is very controversial, though the teams that use it, we also use it sometimes, use it for altered sensorium focal neurological deficits, high spinal fluid protein or pressure, and the presence of tuberculomas or basilar exudates or edema to reduce edema in the brain. And it is claimed that it helps in the short term and also long term in improving outcome, including restoration of the level of consciousness in the patient. So going to surgical, we are dealing mainly with hydrocephalus, tuberculomas, tuberculous abscesses and spine lesions. And as you have seen, hydrocephalus constitutes a big percentage of these patients. Tuberculomas, which are very big, may be taken out surgically through a craniotomy. Tuberculous abscesses, some teams just aspirate it and then continue with treatment, including steroids. And for the spine, generally, there's stabilization where there's instability. But some teams actually don't stabilize the spine. They just start on anti, anti-tuberculosis therapy with the hope that it stabilizes with time. So with hydrocephalus, there's only one way around it, and that is looking for a way of shunting the CSF. Some teams do serial lumbar punctures together with medical therapy, or shunting, or ETV, or a combination. In my small experience with 7 patients whose ages range between 3 months and 2 years and 7 months, only 2 of the 7 patients came with histories that were consistent with exposure to tuberculosis. The rest were non-specific, and all underwent our standard endoscopic surgery with an attempt to do an ETV. But unfortunately, all of them had very severely scarred prepontine cisterns. Even the lamina terminalis area where prechiasmatic cisterns were all scarred, and aqueducts were all blocked. And the only advantage of endoscopy in this case, therefore, would be before shunt placement is to help with direct vision of the ependymal exudates. They are typical. The ones of TB are typical. And this is diagnostic in nature. And it also enables us to irrigate the ventricles to thin the CSF, preventing shunt blockage if medical treatment is started in concurrence with shunting. And of course, there are prognostic factors that we have all considered, but the most important is the stage of the disease when the patient comes to you. And stage 3 carries the worst prognosis. That's the most important prognostic factor in this case. But of course, there are others such as extremes of ages, presence of miliary disease, presence of underlying debilitating disease, hydrocephalus, focal neurological deficits, low CSF, glucose levels, and marked elevated proteins. And difficulties that we are facing in our setting is increasing drug resistance, delay in diagnosis, misdiagnosis in some patients, frail interdisciplinary network, and of course, superstitious beliefs in the communities that hinders patient care, and then paucity of information or data, and then of course, patients are lost to follow up most of the times. Thank you for your attention.
Dr. Jokonya, over to you.
Thank you. Thank you very much for an interesting overview on the management of TB.
Yes.
Yes. So before we go to any questions, I would like to, at this point, call upon Dr. Rihab Fredj, who is from Tunisia. She's a 5th-year medical resident, just to take us through a case, and then we have some time for questions. Over to you, Dr. Rihab.
So it's a pleasure to assist to this interesting and to this interesting webinar. So can I share the screen?
Yes, go ahead, please.
It's okay, or?
Yes, it's fine.
Okay, so I will present a case of a patient who is still treated in our department after 2 months of treatment. So I have the pleasure to share this case. Excuse me. So it's about Mrs. DZ, 24 years old, with no significant medical history. She had headaches for 8 months, right hemiparesis for 2 months, and generalized tonic-clonic seizure the day of admission. So physical examination showed a conscious girl with Glasgow scale in 15, right hemiparesis, right facial paralysis, stage 2 papillary edema, and the temperature with 37. Routine tests, including chest X-ray, were normal. So it's the cerebral CT imaging. which shows left frontoparietal process with an important area of edema with the mass effect. The MRI, so actual T1 GADU, and the T2 MR images delineating better the tumor with its large area of edema. So, is it a tumor, tuberculoma, toxoplasmosis? So we have completed with a thoraco-abdominopelvic tomography in order to find other localizations of an eventual tuberculosis or other infectious disease. So the girl is young to think about a primary tumor. This is the thoraco-abdominopelvic tomography, which shows an agglutinated aspect of the last loop, a retracted mesentery, and a thickened amountum, which may be consistent with digestive and peritoneal tuberculosis. Biology. The tests for BK in the sputum, stomach, urine were negative. The intradermal reaction to tuberculin is negative too. The toxoplasmosis and the VIH serology were negative. So that we decided to do an open biopsy. The anatomopathologic examination concludes on granuloma. So it's an association of epithelial cells, large elongated histiocyte cells, and multinucleated giant cells around the caseous necrosis, acellular, eosinophilic, and granular material. Lymphocytes are present at the periphery. An ileocecal biopsy was also done and concludes to the same result. After a pre-therapeutic assessment, the anti-tuberculosis treatment was started. So, quadritherapy based on isoniazid, rifampicin, ethambutol, and pyrazinamide, a corticosteroid treatment with progressive dose regression, and anti-epileptic treatment. So we choose the medical treatment because the tuberculosis, as we know, is a medical disease. So we can treat medically. The evolution after 2 months of the treatment instauration, we have headache regression and improvement of motor disease deficit. So that actually we are after 2 months of the instauration of the treatment, and the radiologists have suggested images, MRI or CT imaging after 3 months of the treatment instauration. So thank you.
Thank you very much, Dr. Riab, for an interesting case discussion. So I think TB does bring about a dilemma in terms of diagnosis, particularly when you've got images, CT scans and MRI scans that are showing appearances that might look like TB, but there are also quite a number of differentials. Dr. Onen, you did speak a bit about the various ways in which one can make diagnosis for TB. Would you have any pills, for example, that someone can use to sort of differentiate between these lesions on a CT scan or MRI scan that might look like TB, but they could also be something else as well?
Other things that might look like TB?
Yes, pills in terms of things that can help us to make, for someone to be confident in the diagnosis of TB, given that there are so many differentials or things that will look like that as well on CT or MRI imaging.
It is generally said that TB is a mimic of so many other diseases. And you remember in my presentation, I said that 25 to almost 70% of the clinical diagnosis actually is what guides you and convince you to say that what you're seeing on the scan is TB. But usually, in many cases of TB meningitis, when you look in the basocystal area, and you'll always see exudation, scarring in the basocystal, thickening on CT scan. Even without contrast, you see contrasting in the basocystal area, and sometimes total obliteration of the prepontine. That is one thing that should guide you towards TB. Then when it comes to tuberculosis, it's quite difficult to differentiate, except if you're in a place where you have a good MRI system with spectroscopy, then you might be able to say that, one, this is benign. And then of the benign lesions, what could it be? So it's always a collective of many things that will enable you to say that this is TB, this is not TB. And of course, tuberculosis abscess, many times it's mistaken for an ordinary bacterial abscess. But if you also have an X-ray and you've done a chest X-ray and you're able to see a primary focus in the chest, that's one thing that will also help you say that this is possibly TB that I'm dealing with. So it's a collective of signs and symptoms that will convict you that this is TB in the brain.
Indeed.
I don't know whether that answers your question.
Yes, thank you very much. And also, one more thing, if I may ask, with regards to ETV, the management of, what would you say is the role of, or if there's any role at all, for ETV in the management of tuberculosis meningitis, given that, you know, you've got quite significant scarring in the ventricles and things like that?
Yes, as I told you, of all the 7 patients I've ever worked on, all of them wound up with shunts. We started off with an endoscope and then ended up putting a shunt. Why? Okay, the advantage of doing ETV is that you will be able to visualize the exudates directly, which are pathognomonic of TB. You'll be able to see them on the epidermal lining, that ventricular flow, and sometimes blocking the aqueduct of Sylvius. So for visualization, it helps you diagnosis. It strengthens your diagnosis of TB. But then too, your scope enables you to irrigate the ventricles. And that allows you to thin the CSF. Once the CSF is thinned, if you put your shunt with concurrent initiation of treatment, the shunt will not block. So you understand, that also helps in that way. And of course, if you found, because on fenestration of the floor into the prepontine, if you find severe scarring, then obviously there'll be no resorption. So you cannot go ahead and say that your ETV is going to work. The best way to go is a shunt, but make sure that you thin the CSF with irrigation. In this case, with Ringer's lactate, because it causes less of those electrolyte imbalances. Ringer's lactate, and then you put your shunt. The shunt will always work if you start treatment at the same time.
All right. Okay. Thank you very much. I see Dr. Musara has got his hand up.
Yes, I just want to ask Dr. Onen, there is a famous procedure by Benoit, which he was doing in Uganda, where he talks about doing cauterization of the iliac plexus at the same time. I just want to find out if he tried including cauterization when he was doing or when he was attempting the ETV.
So doing cauterization to delay the progression of the hydrocephalus, we didn't try in the 7 patients. Possibly that should be the future. We should try it possibly in the future and see whether it works. Because I read in an article where it says that serial lumbar punctures in some patients with the initiation of treatment has worked. That after beginning treatment, the scarring disappears and therefore the CSF pathway reestablishes. A few articles talk about that. I've never tried that.
Okay.
So in all the 7 patients, on seeing scarring of the basal systems, we decided to put shunt straight away.
All right. Thank you very much, Dr. Onen. Okay. All right. So moving on, I'm going to hand over to Dr. Ignatius to introduce our next speaker.
Thank you so much, Luxwell. It's an honor for me to present Dr. Musara. He's a consultant neurological surgeon in Harare, in Zimbabwe. But he's here today in the capacity of the Vice President of the Continental Association of African Neurosurgical Society. Dr. Aaron, we are very honored to have you today on board, and it's a great honor for you to talk to the young African neurosurgeons. You have the floor. You can share your slide, Dr. Aaron.
Okay. All right. Thank you very much, Dr. Ignatius, for the introduction. So I'm talking about the presentation and just giving some management excerpts for spinal TB. So TB of the spine, which is also commonly called Pott's disease, is both the most common and also the most dangerous form of TB infection affecting bone. It usually occurs from spread, which is either from the pulmonary or abdominal TB. And delay in establishing diagnosis and management is often associated with spinal cord compression, paralysis, and spinal deformity. And it is a disease of concern, especially when you look at Sub-Saharan Africa, where HIV is also endemic. When you look at this world map showing the distribution of spinal TB, spinal TB according to the WHO in 2019, you can tell it's a disease which is quite common in Sub-Saharan Africa, like I've alluded to, and also in parts of Asia. When you look at the anatomical involvement, you find about 12% of cases occur in the cervical spine. And at the cervical thoracic junction, it occurs in about 5%. And then 42% occurs in the thoracic spine. So the thoracic spine is the most commonly involved anatomical site of the spine in terms of TB spine. And then 12% occur in the thoracolumbar junction area, while 26% occur in the lumbar area and 3% in the lumbosacral area. Rarely do you find TB spine occurring involving just the sacral segments alone, without it occurring in a conjunction with the lumbar spine. And therefore, when a lesion is seen in the sacral spine, it's most unlikely to be TB. We need to consider is something else first. When you look at the presentation, pain is the most common complaint occurring in 95% of cases. It is often of a diffuse nature and often localizes quite late. And therefore, this does affect the presentation. And so in Africa, presentation is usually quite late, spanning from a period of about 3 months into several years, and with an average of around 1 year from the time of onset. Pain may also be radicular in nature if there is the involvement of a particular nerve root, and the affected area of the spine tends to be tender on palpation or on gentle percussion. Stiffness is also an early symptom which sets in several months before presentation, especially in our setting. And it is because of paraspinal muscle spasms. you tend to find constitutional symptoms like fever and weight loss occurring in about 40%. And usually, if you find the presence of constitutional symptoms, it may often mean you have a concomitant active pulmonary TB or abdominal TB. So you might find the occurrence of cold abscesses, like you have with this here, this collection of pus. And sometimes it may manifest as a non-healing wound following incision and drainage of what may appear like an ominous abscess, which the one will just attempt to drain. And cold abscesses or deformities which do occur on bone, they can compress the spinal cord, causing upper or lower motor neuron signs which can be elicited on a patient examination. In terms of spinal deformity, so usually one can pick a gibbous deformity, or especially in children, an exaggerated kyphosis of the upper thoracic spine is a common presentation. So the deformities, like I've alluded to, will take the form of a kyphosis, a kyphoscoliosis, and it can be in the form of a gibbous. And with a delayed treatment and more continued compression of the spine, of the spinal cord, the patient may present with paralysis or even paraplegia. And deformities, they tend to be a common occurrence in children who may sometimes present even without pain. Tenderness of the spine on the site on palpation is an important sign which can suggest the presence of TB. And when involving the spine below the conus medullaris, sometimes the patient may present with hypotonia, hyporeflexia, and reduced power. In order to be able to speak better on a prognosis, making use of the staging systems is a useful tool, like the Tully and Kuma staging, which stages attend to stage 1 to stage 4. In stage 1, a patient is unaware of any neural deficit which may be present, and often the deficit is often negligible, but the physician may detect some plantar extensor increased reflexes and also some ankle clonus. While in stage 2, the patient may be aware of the deficit, but is able to work with support, though with some clumsiness, and this is often considered a mild deficit. And then in stage 3, there's paralysis in extension with a sensory deficit, which is up to about 50%, which makes it a moderate deficit. Then in stage 4, you have the features of stage 3 plus some flexor spasms and paralysis and flexion, which may be flaccid in nature as well. And there'll be some sensory deficits with some sphincter involvement. So this is the most severe form of Hippo's disease. And these stages do correspond with the subsequent prognosis with treatment. It's also important to be able to differentiate spinal TB from other diseases like spinal hypoegenic infection, and how to differentiate this from spinal TB. It's often to do with the duration spinal TB tends to take several months before it presents. So if a patient has come in maybe within a few days or a few weeks, you want to seriously consider a spinal hygienic infection. There's also need to consider atypical spinal infections like aspergillosis, especially in the immunocompromised patients, and you need to consider it. There's also need to consider malignancies, which do occur, especially when you find this multi-level involvement. That may speak to the presence of malignancies as well. Now, the mainstay of treatment for spinal TB remains is medical management. Surgery, it comes in for a complication avoidance and complication management. The aim of most of the surgeries was initially just to correct spinal post-tubercular deformities before, but now the pattern is changing. Recently, a more aggressive management approach has been adopted so that compression is alleviated in the very first place, rather than waiting and then trying to deal with the post-tubercular deformities which occur after the completion of medical treatment. So when surgical management first came in, the first attempt was that laminectomy decompression, but it was associated with its failures because it was failing to address the anterior compression disease. And also it was creating instability. And therefore, the patient would sometimes end up being worse than it was before, because most cases of spinal TB involve the anterior column rather than the posterior elements. Now, posterior fusion techniques that reduce drastically the deformities which do occur is now considered a good choice, but it was associated with some post-operative infections, bacterial infections, and post-operative kyphosis sometimes, and some instrument failure. So it is still a very useful tool today, but again, there's further progression, further development of surgery today, so that anterior approaches are now tending to be used a little bit more to try and address the disease right from the front where it is coming from. And therefore, the anterior surgical approach is gaining some more ground. So it's important to note that surgery done during the active stage of the disease is actually safer and gives a resolution of symptoms faster and better than when it is performed when the disease has been considered cured, like has been considered the case for a very long time. So in conclusion, the importance of early diagnosis, the starting of appropriate treatment, and its continuation for an adequate duration with proper counseling of the patient and the family members regarding timely surgical intervention is very important for achieving success and a good outcome in the management of patient with spinal TB. Thank you very much. Ignatius knows this place. He has enjoyed it before. These are the mighty Victoria Falls, which you can view like this from the Zimbabwean side. And we will welcome you. You know, our borders are still open. Thank you.
Right. Thank you so much, Dr. Aaron. Thank you so much. It was really an excellent presentation. Sorry, looks like we're having some changes in the program. Dr. John is having an emergency, so he needs to present his case so I can go to the OR. So can you share the slide? Dr. John Jabang, he's the pioneer neurosurgeon in Gambia, and he's one of the founding members of the Young African Neurosurgeon Forum. He's a very active member in the forum, and he has organized many courses in West Africa on behalf of the forum. John is a very good friend, and he's going to present a multi-center study which we're going to conduct in the continent. John, can you just go with your presentation before you go to the OR?
Dr. Ignatius, is John's mic on?
And let me see.
Kindly unmute your mic, Dr. Jabang.
Yeah, can you hear me now?
Yes.
Excellent, thank you.
Just a second.
Share your screen, John. Yeah.
So that's it. So I'm saying thank you so much, Ignatius, and thank you everyone who is here, especially my predecessors who have presented, senior colleagues. I've learned quite a lot from your presentation, and I would have loved to be here throughout the end of this presentation, but unfortunately, as usual, there's an emergency to attend to. So I'm going to just look at a proposed multi-center prospective cohort study on POTS disease in Africa. And I'm sure that, I don't know about you, but you must have had a patient, spinal tuberculosis, a patient whom, ranging from one patient to another, you find it difficult to make a decision when it comes to spinal tuberculosis. The question was asked earlier on, and somebody was saying it's not only based on one thing that you would do. So you've got a patient that come, you look at the image and it looks suspicious of that, the history. This is positive, that is negative, this is positive, that is negative. And in Africa, you want to look if we have really studies that will actually help us to get this thing better, you don't find it. So as an introduction, we all know that tuberculosis is a burden in our own part of the world. We basically need good research. We need prospective works that are done in our own part of the world where the burden of the disease is, to be able to guide us into good, guideline clinical evidences that we can use. Now, it's very interesting as I looked at the literature and saw this paper by Sven Hope that talked about the most influential literature in spinal tuberculosis. And something that was very interesting, he said, a global disease without global evidence. When I saw that, I laughed. I'm sure most of you have seen this paper. For what's very interesting in this paper, now you realize that the top 3 countries where they were able to get influential papers about tuberculosis of the spine were actually from India, the United States, and China. And these in total published more than 51% of all articles. And again, on this paper, even outside this paper, we know that the burden of the disease, 60% of it would be found within our own part of the world. And unfortunately, centers from Africa only contributed about 4%. So in this paper, they concluded by saying that India and the Chinese researchers dominated evidences in spinal tuberculosis. Other areas with high disease burdens, such as Africa, do not feature. Most publications are retrospective studies with low level of evidence. So if you look at that, we have the high burden of disease, yet we have the least in terms of publications. So, and I think that with time, we have to change that status quo. Again, I saw another review. This was a systematic review and a meta-analysis, and it looked at the trends of spinal tuberculosis research from 1994 to 2015. And this was very interesting. You saw that after 1996, in fact, there were no, the number of publications from 1996, they had one of the highest number of publications. And after that, it was only until 2015 that they have more publications, that there were more publications than 1996. So again, if you look at this, it shows you the countries where POTS disease have been published. The US taking the lead, followed by India and then China. And as you look at this, it's only South Africa that seems to be appearing as, a country within the African continent. And that just shows you, in terms of publication, we are not really doing as much or we are not presenting so many good papers so that we also can be ranked. And if we have the disease burden much more than any other person, I think it's a moment for us to do some works, prospective works, where we can be able to, present good stuff. And as a result, this whole presentation is aimed at sharing a little idea on a multi-center prospective cohort study that is going to look at the clinical, the paraclinical treatment and outcome of POTS disease in Africa. And also, having said that, most probably move on to having guidelines that will result from all these studies that we will do in all the different countries.
Dr. John, sorry, you're giving an excellent talk, but the top of your screen is being closed by the bar of the panel members. Do you mind moving that so we can see the excellent talk you're giving?
Are we good?
Yes, we're good. Thank you, sir.
Okay. All right. Thanks. So how do we intend to go on about this? One, we want to identify different centers in different countries within the region and also have leads in those countries. We want to share and discuss some of the questionnaires and protocol. A part of it I will share with you today. Obviously, we'll ensure that there's some ethical approval. We'll work together to ensure that we are able to have some funding, because some very good research, if you want to do a very good prospective work, you will surely need some funding. And finally, obviously, to start the project. Looking at it, we just thought that a simple questionnaire would do. And this is what I want to present to you today. So section A is about demographic information. Sex of patient, age of patient, date of birth, marital status, education of patient, occupation, lifestyle, whether they are smokers or not, whether they are alcoholics or not, travel history, we know that's important. Past TB history, and also obviously other past medical histories. Clinical information of patients. We still know that cough, fever, weight loss, night sweats are things that we ask. And I know different people, as you meet them in the clinics, especially patients with POTS disease, some will have this, others wouldn't have the rest. Pain, is it going to be cervical pain, dorsal pain, lumbar pain, radicular pain, any type of pain, stiffness, swellings, gibbosities that we see. I so much say that in my clinic that when I see a young person in Africa over here in my own clinic having a gibbosity, I would say it's TB until proven otherwise. I don't know if that's your experience in your centers. Curvatures, of course, sphincter disorders, neurologic deficits, abscesses also, and abscesses, you classify them. Is it median abscesses, paramedian abscesses, unilateral abscesses, bilateral abscesses, sinuses, the same thing, you characterize them. And then we could have some classification. So I'm just looking at, there's several classifications out there, but I was, my attention came to the one by Atul Goel from India. And of course, we can use the paraplegia classification from Frankel, or we can use other classifications. And again, let me just stop by saying that this is still a work in progress. As I know that many people that are here who've got so much wealth of experience in POTS disease than we do. When we adopt this, there would be a lot of changes and we would actually make it better. Again, we look at section B, which is radiology, ranging from X-rays to CT scans, to MRI, to ultrasound scans, to different radiologic investigations. Then we will look at radiologic diagnosis in terms of localization of the lesion. Is it cervical, cervicothoracic, thoracic, thoracolumbar, lumbar, lumbosacral, and so on. And then we will get to the laboratory investigations. And now this is the thing. One thing I'm very much interested in the laboratory investigation is to know what is the sensitivity of, let's say, for instance, for every patient of mine, we will do these investigations for them. One of the ones, two investigations here we don't do for most of our patients here. So the interferon gamma release that we don't do back home, it's not yet here, but it's something that we want to adapt. And cultures we don't do, but we will do full blood count, ESR, CRP, PICT, AFB. Now most of the times it's gene expert we do here. That's tuberculin skin test. And I would be very interested to know in this prospective study, what is the sensitivity of each of these, ESR, elevated ESR, CRP, PICT, AFB, because if I show you my list of patients, you would see a number having elevated ESR, elevated CRP, some they don't have. Mantu is positive for some, it's not positive for some. So quite a lot of a whole diverse thing. But then if we have a prospective work, we can look at what is the sensitivity of each of them. And then from there, we can now come up with a score where, you know, each of these is kind of given a score based on the sensitivity. And I think that would be something that's very, very interesting. Again, you can talk about admissions. What was the indication for admissions? Most of the patients with POTS disease are really not admitted in our setting. And I'm sure that also happens in most areas. Of course, there are indications for admissions. The last patient we admitted in my setting was a very, very young pediatric female who had, you know, a sinus that was draining, and she was absolutely cachetic. I think that was the last patient we had, but most of them, we don't admit them. It's the therapies that we give them, and they go on. So again, the duration of admission, are there morbidities, is there any mortality? And then section E, we look at the treatment, and then the treatment, the chemotherapy, a lot have been discussed, other additional medications. In terms of pain, how do you manage the pain, the use of steroids, the use of other medications for the different neuropathic pains that they have, radiculopathies that they have. So all those would be important. And then comes surgery, and then is it combined? Did we do both chemotherapy, obviously, and surgery? In terms of chemotherapy, it would be good to know what the inclusion criteria for that treatment is. We would try to lay criteria for those that would only need chemotherapy alone. And also we would want to look at the duration of therapy. We want to look at the drug side effects, and also other additional supportive therapy. When it comes to surgery, of course, in the literature, what is said, the inclusion criteria for patients in the surgical treatment are large cold abscesses, progressive or severe neurologic deficit, large sequence spectrum, and you know, and so on and so forth. But like Dr. Aaron alluded to, I think we need to look at two things. One, what is the immediate? So if we want in terms of outcome, patients, because a good number of patients in my setting that have these criteria are not even operated. Not all neurologically deficit patients are operated. And in the long-term outcome, they regain all their function and they are up and about working. So the question is, we need to look at surgery or not surgery is really a neurologic deficit, or what type of neurologic deficit is to be operated. And even if we can, as we look at them in various cohorts, in various areas, we could compare those that present with a certain classification who were operated, or certain grade of classification who were operated, versus those that present with the same grade of classification. So let's say if we take Azouz classification, class 2, we say those class 2 or class 3, in the Gambia, let's say they are operated, say in Harare, they are not operated, or in that other, in some other place, they are not operated. And then we look at what the long-term outcome is going to be. And that would really help, that would really help us. Again, these are some of the other things. Going to section G is follow-up. And in the follow-up, we need to assess the clinical progression of these patients. So those that come, inability to walk, weight loss, fever, and then we see them again a few months after that. We like to see them a month after, and then 3 months after, and then let's say 6 months after that. So we see them progressively to see, has the fever subsided, has the weight loss started, has the patient started gaining weight, is the appetite getting much better? In terms of the pain, the back pain, is it well controlled? In terms of the weakness, the neurologic function, is he getting much better? In terms of the sphincter disorders, is he getting much better? So the follow-up would actually look at the progression of the disease. Again, we will go to the laboratory progression. So all the laboratory workup that was done at the beginning to lay the foundation, to make the diagnosis, we would want to subsequently repeat those investigations to see how they resolve as the patient evolve. And also radiological progression, which of course is very challenging. I don't know, but for the Gambia, an MRI, the cost of an MRI is not within reach for everyone. It's a bit expensive to most people, but again, if we have a study that is well sponsored, all these things, you can be able to follow them basically from one stage to another, even radiologically. Of course, as problems of lost, people being lost to follow up, which is very characteristic in our own part of the world, due to various factors and also mortality. So in terms of outcome, if they are admitted, we want to know what their date of discharge is, the clinical outcome, like I mentioned earlier on. And then, of course, having said that, I would just want to conclude by saying that this simple presentation is just a work in progress based on a lot of things that we do in my own setting here in the Gambia. And it would be a good thing, as Africa is rising. SN like to say that Africa has already risen. But anyway, conducting our own high-level research is really, really very imperative. And I think that the need for the South-South cooperation, we talk so much about the South-South cooperation. I think the time has come for us to really get that South-South cooperation, ongoing. And one of the ways we can do it is actually to do some multi-center prospective studies or multi-center retrospective studies where we can all collaborate and we can learn a lot. Having said that, thank you all so much.
Right. Thank you very much, Dr. John, for the talk. It is indeed quite a challenge that you've brought. I mean, for us as a continent. But before we release you, there's a question here on the question and answer, on the question segments from Runyara Romano. It says that it looks like the research is focusing mainly in adult patients. Are pediatric patients part of the research?
Oh yes, so the research is focusing on all type of patients. So we see, as a pediatric neurosurgeon, but I am myself. So the research is not focusing only on adults. It's for all patients. I don't know. Probably he saw something that made him think probably we are more dealing with the adult patients. But no, it's focusing on all patients. Sorry, my video was off. Sorry.
All right, thank you. I'm gonna ask Ignatius to also just give a comment before we go on to the next.
Yeah, well, thank you, Luxwell. John, that was really very impressive, and this actually is taking us to the next level of our activities with the young African neurosurgeons. After capacity building, we need to translate, the knowledge we have into practice, and we'll be discussing this next month in April. I know you have to dash the OR for your emergency, but I think next month people have ample time to be able to ask a lot of questions about research. Thank you so much, John, for coming. Really appreciate your presence. Good luck in your surgery.
Thank you. Thank you.
Thank you very much, John. We can release you now to got your surgery. So now I'm just going to introduce Dr. Heba Azouz to just give us a clinical case on Pott's disease. So she's a neurosurgeon at the Children's Cancer Hospital, as well as an assistant lecturer in Egypt. Over to you, Dr. Heba.
Thanks a lot for the introduction, and thanks, Estini, for the great work and the cooperation. It's such an amazing webinar. So let's start. Actually, I don't think that I have a lot to share after all those nice presentation, but let's go through it. So we will be discussing about Pott's disease. First of all, you already know about it. It's tuberculous spondylitis. It's first presented by Percival Potts, and it's a very old disease. Like it was documented in the ancient Egyptian history and South American history. You already know about the epidemiology, and now there is a surge in the cases number, and that's maybe because of the increase of the HIV. Some contributed to a secondary migration phenomena. We already went through the epidemiology, and it's the number are increasing, and in WHO reported 10 million cases in 2011. And the pathophysiology, we already went through it, as well as hematogenous spread, and it's more in the paradiscal space. And then the second part of the body is the central part. The thing about Pott's disease or about TB, it's the late presentation and the vague presenting symptoms. So many cases have different symptoms to present. Like the common cases is like the late presentation, back pain, vague back pain, breast pain is the pathognomonic part of it, deformity or motor defect, cold abscesses or mass. The presentation is more in the lower thoracic spine than the lumbar spine. It has also documented in cervical spine in 10% of the cases. As you can see in the picture, it leads later on to kyphotic damages and also to neurological deficits. So the evaluation, the culture is the golden standard, Liechtenstein virus. TB clean test is high sensitivity, like 84 to 95%, but it's not for HIV patients. That could result in a negative outcome. Plain X-ray could help us in cases of deformity clear or in just TB in a milligram TB, and then the CT scan that could help us in documenting the case. So while we assess the cases, we need to know what kind of the lesion that's there. This is just a quick diagrammatic pictures to assess the damage of the body and the kyphotic angle, and that could lead us to a proper management of the patient later on. So going back to the case, we had a case of a male, 35 years. He presented with a foot drop after carrying a very lightweight object, but he had a history of a very long-standing back pain for the last 6 months. So that's what his MRI, nearly the body was collapsed. So before actually documenting or diagnosing him with a TB or pulse, he went for decompression and laminectomy and post-fixation. That's one thing. Another case, I just go around it very quickly to give you the point of this presentation. She was a female, 20 years. She was referred from a chest clinic because she had chest symptoms. And on the investigation, they found that's dorsal infection. Hence, the patient didn't actually compromise with any neurological deficits. She continued on with her medical treatment because she was already diagnosed with a TB. So we have 3 major clinical features that we're talking about, whether it's a cold abscess, or there's a neurological deficit, or there's a kyphotic deformity. And that's helps us in the management, because the very important thing about management now is drug resistance. And that's the case. And that's what we need to avoid, giving patients irrelevant medication upon our primary diagnosis. So the role of the management, we have to ask ourselves, why are we doing this? Why are we doing this exact step? Is it to obtain a diagnosis, or is it for the spinal decompression, or is it for the alignment, like for the kyphosis? And then the management could be different. We could actually use the Frankel grading to assess the motor assessment of the patient and to give us a prognostic factor of the outcome. So if there is actually to obtain a diagnosis, we could go for a percutaneous needle biopsy to obtain a culture if there's a no neurological deficit, or then laminectomy and decompression for the spinal cord. And if it's alignment, it's the fusion. And then come the question of, is there internal fixation of bone graft in an affected milieu is a good option or not? Greg and Kumar actually advocated in the fixation in an infected area and thought that would actually heal or help the prognosis more. Other suggested that adding a part of the anterior part or from the anterior segment could actually help in fusion in a posterior approach like Zangara. And we have to go back a step back. What is the management of the goals? Is it to cure the infection, so we can go for a medical treatment, or to prevent the drug-resistant tuberculosis, and to prevent or to correct the disability of neurological deficit, putting in mind that most of the cases actually then had ischemia in the tissue, and that's hinder the prognosis. This makes it not capable to retain their full motive power. And lastly, but not least, we want to prevent the relapse of the symptoms, because as known for mucotuberculum, it can stay dormant for years until it's active. And that's something that we have to put in mind. And thank you.
Thank you very much, Dr. Heber,
Yeah, sure.
for an excellent presentation. Okay. So at this time, I would want to hand over to Ngobele.
Hi, everyone. Can everyone see my screen?
Yeah.
Okay. So as highlighted by John, there is a huge discrepancy with the patient burden we see and our research output. So a team of us together with Cons are going to be running a research symposium, and basically we want to set a foundation of solid research methodology in an aim to increase the output that we're currently producing on our continent. This course, along with the team, was helped to put together by Dr. Ursula Rawing, who's in neuroscience at the University of Cape Town. And all of us as a team were able to come up with a 5-block course. I will hand over to her so she can just give a bit of an introduction, since we will be launching onto this next month. Over to you.
Thanks so much, Nobile. So I'm very excited to be able to introduce this course, which we've put together for the purposes of increasing the research capacity amongst neurosurgeons on our continent. And as Nobile mentioned, it's a 5-block program, and it will essentially cover the essentials that neurosurgeons need to know to establish and grow their academic research careers from start to finish when it comes to research projects. So we start with the introduction next week, and we've got some great invited speakers, including Prof Fredj, who's also the education chair of CONS. And then block 1 will really focus on refining the research question and the study design and writing a research protocol. Block 2 will look at different kinds of data, how to set up the right infrastructure to conduct your research and to obtain the right approvals. Block 3 will look at statistical analysis and appropriate interpretation of data. Block 4 will look at reporting and presenting data, both for publication, for thesis writing, and also for academic presentation. And then we'll end off in block 5 by looking at how to grow career paths as academic neurosurgeons and the various milestones that are important to think about, supervising students, attracting funding, establishing an international reputation, collaborations, and really making an impact with research. So we hope that the course will be very hands-on as well, and will potentially give rise to further sessions that we can offer based on need and interest of the different participants. And we really hope that we can also contribute with mentoring sessions in between the different courses to try to address some of your individual questions or your areas where you are looking for some advice. So please do join us, and we look forward to starting off next month.
Thank you very much, Dr. Rawing. Dr. Ignatius, over to you.
Ursula, thank you so much for the course overview. I mean, it's quite exciting, and I'm sure next month on April 24th, we're going to start up something different from what we've been doing for the past few months. So on this note, on behalf of all CANS AC, I want to thank all the speakers for the excellent presentations they've given so far this evening, and all the young neurosurgeons who've attended this webinar. So looking forward to see you next month, April 24th. It's going to be quite exciting to have a lot of great speakers from the world, Professor Benzel, Professor Tony, there's Angelos, and a host of others who are going to come in to make sure that our research course is successful. So thank you so much, and see you next month. Bye-bye.
Bye. Is there a final word from the moderator before we end the session? Thank you.
That's all right. Thank you very much for attending the course. Hope to see you next month. Bye.
Thank you very much, everyone. Have a great evening, and thanks again to all the wonderful speakers. This talk will go up on our YouTube channel also, and it was a really honor just to have such a diverse panel, and all of us came back with a lot more knowledge in the end. Thank you. Bye, everyone.